Yep. All right. Hello, everyone. Welcome today. Thanks for those of you that are in-person audience for coming out, and hello to our virtual participants. My name is Adrienne Fernandez. I have been with the Lupus Foundation for about 13 and a half years. I handle grants and projects management, and I'm going to be your facilitator today. We have a great program lined up. Just to give you a couple pieces of information, Chris over here is our communications coordinator. Alex is our digital assets manager. Most of you know our legend here, Suzanne, and she's around. So if you need anything, please ask them. Also, I do want to say that for the in-person guests, the restroom is just to the right down the hall, so on your right-hand side. And so keep that in mind. And also, I've been told that toilet seat's a little loose today, so just be careful, ladies, when we're sitting down. So I have to say that for safety purposes, okay? And again, welcome to our virtual participants. After each speaker, we are going to have a Q&A session. If you have any questions, please raise your hand or place them in the chat. We'll do our best to get them answered. I do know we have some people who were unable to make it at all today, pre-submitted some questions. So if those aren't answered, I'll do my best to ask those. Again, make sure that the questions you ask are general and not super specific to your medical case, and that they're related to the topics we're talking about today. And as a brief disclaimer, remember that the information provided during this program is for educational and informational purposes, and it's not a substitute for your physician's advice. At the end of the program, we are going to hand out, or in the case of our virtual participants, we're going to email an evaluation. Those evaluations do help us to get grants and funding, so please make sure you take the time to fill those out for us. And for our virtual participants, we will email some of the materials that our pharmaceutical companies that are joining us today passed out. I want to give a huge shout out to our funders, the Ohio Commission on Minority Health, GSK, Biogen, and Genentech. Without you, we would not be able to have programs like this. We truly appreciate your support of autoimmune disease and lupus in particular. And we are really grateful to have Juliet and Eric and Tom from, we have Juliet from GSK and Tom and Eric from Genentech. So if you haven't had a chance to talk to them today, please do. They have some literature they're passing out. I'd like to give them a warm welcome, but they're not in the room yet. And also just to say thank you to Cleveland Clinic for the support of this program. Last but not least, thank you to our panel of physicians. We have Dr. Laura Provenzano, Dr. Heba Wasif, and Dr. Emily Littlejohn. So thank you all for donating your time and your talents to the Lupus Foundation, and for all of the incredible care you provide lupus patients each and every day. All right, let's get started. We do have, for those of you with an agenda in front of you, well, we haven't passed them out yet, so you'll get those. We have a little bit of a switch in our order. We're going to start with Dr. Emily Littlejohn today. Dr. Emily Littlejohn is a rheumatologist in the Department of Rheumatic and Immunologic Diseases at Cleveland Clinic and holds a faculty position of clinical assistant professor in the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. She directs the Cleveland Clinic Lupus Cohort and is co-director of the Lupus Clinic. Dr. Littlejohn will present on current and emerging biologic therapies in treating SLE. Please welcome Dr. Littlejohn. Yes.
Hi, everyone. Happy Lupus Awareness Month. Thanks to the LFA for having me here. I'm going to start off with a little bit of background about lupus.
Can you hear me now? I just was saying, welcome. Happy Lupus Awareness Month. I want to just go through my agenda briefly, which is I want to just go through what everyone here probably knows about the mechanism and cause of lupus. I see it's also kind of here in the schematic. We'll talk about current biologic therapies and sort of where we're heading in the future. And I'm going to give you some patient cases of our clinical trials in CAR T therapy, which is our newest and coolest type of biologic therapy that we're offering here at the clinic in phase 2 trials. So without further ado, this is the agenda. Like I mentioned, we'll review the complexities of lupus, current therapies for lupus, and then review upcoming emergent therapies for lupus. So this is a schema here of the scientific landscape of the mechanisms of lupus. And I just want to put this up here just to underscore how complicated lupus is. And I think most people know that, not one person's lupus is the same. We talk about the lupus fingerprint often in my clinic, and I say no one person has the same fingerprint as somebody else, just like no one's lupus is like anyone else. And that is because of this here on this slide. You see all these different mechanisms of inflammation and the inflammatory process. There's a lot to this slide, so I won't go through all of it. But you'll see here also there's targeted medications at different steps of this inflammatory pathway. And this is why it is so challenging to treat lupus, because there are so many different mechanisms that cause the different symptoms that our patients have. Next slide. So the outer ring here is all the different types of symptoms that patients can have. You see up in the upper left, renal disease, heart disease, cardiovascular disease, skin disease, photosensitivity, neuropsychiatric lupus, which is brain disease, etc. And that's all in the outer ring. The inner ring here shows the mechanisms or the immunological heterogeneity of lupus that we see. And we think different parts of the inflammatory process that are disrupted or abnormal are responsible for the different parts of the symptoms that present. So for example, at the bottom here, you see neutrophils, and we think when neutrophils go awry, that causes some of our vascular symptoms, such as Raynaud's phenomenon, when people's fingers turn blue in the cold. And the joint disease we see with swelling and stiffness of the hands, along with things like fatigue. So it's very complicated to treat lupus, as most of you probably know. Next slide. So this is sort of the way that we approach treatment of lupus, depending on different body areas. Alex, can you press some more? Yes. So this is the full picture, and this is just from my perspective here. So there's lots of different ways to treat lupus. This is the way that I look at it when I approach patients, depending on where they have the lupus, is really what we target. Other than the medicine hydroxychloroquine or Plaquenil, every other medicine that we add to lupus patients is because of different organ involvement, which is why most people have different treatments than others. Next slide. So this is the current treatment that we have for lupus, which are FDA approved. So hydroxychloroquine, which everyone probably here knows about, or Plaquenil. The next one is Benlysta or Abilibimab, which is a newer drug that was approved in 2011, methotrexate, azathioprine, mycophenolate or Cellcept, tacrolimus, voclosporin, anifrolumab, obinutuzumab, which is a newer medicine, and cyclophosphamide. So we'll just go through all these briefly just to give you a little bit of background, and then we'll kind of focus in on the biologics. So everybody knows prednisone, right? It's our best friend and our worst nightmare at the same time. It's very fast acting. It's excellent for joint, skin, any kind of internal organ lupus flare. The issue is that it's a tempering measure. So it kind of brings the inflammation under control quickly, but there's tons of bad side effects, even at 1 milligram over time. These include weight gain, stomach upset, brittle bones, hair loss, etc. And again, this is really not for long-term use. About 10 years ago, everyone was on 5 milligrams of prednisone long-term, and we no longer do that. And I'll tell you why. Next slide. Okay, so I put this up here just to explain here the different dosing of prednisone. As you see, low dose is something less than 7.5, medium dose is 7.5 to 30, and high dose is, here it says 30 to 100. Usually it's accepted that greater than 20 is considered high dose. And what's interesting about this is that we've now found, Dr. Petrie, who is this lupus maven out of Johns Hopkins, she found that even 1 milligram of prednisone over time, just 1 milligram, can put you at risk for osteoporosis. So 1 milligram puts you at 1% increased risk of osteoporosis every single day. So imagine people who are on 5, 10, 20 milligrams every single day. Your risk of osteoporosis goes up along with many other types of things, terrible side effects. Next slide. Hydroxychloroquine or Plaquenil, I always joke that I should be sponsored by them. This medicine is the lupus life insurance. And we say that for a reason, because this medicine is very slow acting. It's good for joint pain and inflammation. It's safe for pregnancy, but it really takes 6 to 9 months to take full effect. I know this is 1 to 3. It's really more like 6 to 9. So compliance is really key. And the reason is that this medicine really needs to get into the body fat and be in stable levels in the bloodstream. No, go back. Sorry. Everyone knows the big thing with the medicine Plaquenil is you need to get a yearly eye exam, because that is the only negative effect is that it can deposit in the eye and cause vision loss or blindness, which in some cases is not reversible. Another Petrie, Michelle Petrie, like I mentioned, who is an excellent physician out of Johns Hopkins. She talks about all the different benefits of hydroxychloroquine, which are here. Sorry, this slide did not come out very well. But not only does Plaquenil reduce flares, reduce organ damage, it can also help improve your lipid profile, so cholesterol. patients with lupus, as Dr. Wassef will probably talk about, are at increased risk of atherosclerosis. It can reduce types of blood clots. It decreases cancers from lupus. And the biggest thing is that it improves survival. So the bottom right here, you see, this is the only medicine that we have in lupus that really does prolong survival in our patients. So everybody should be on Plaquenil unless you really can't take it from an allergy or from an eye perspective. And compliance is key. And now we can check that with a Plaquenil level, which your physician may or not be checking. Okay, so biologics. What are biologics? Well, these are treatments that are derived from targeting components of a living biological system. These are typically large, complex molecules, and most often are what's called a monoclonal antibody or a fusion protein. These are just big words for different proteins. And these are produced through what's called recombinant DNA technology, and they target specific immune pathways. So those pathways that we saw on that first slide, biologics really are finding one of those pathways and targeting them directly. There are currently 3 that are FDA approved: Benlysta, which most of you probably have heard of, anifrolumab or Safnello, and our newest obinutuzumab, which is now approved for lupus nephritis. So these are the 3 biologic therapies that are approved for lupus. So we'll go through them briefly. So this has been Benlysta, initially approved in 2011 for systemic lupus. This is really changed the game. It was a first time this was any medicine that was only for lupus. Every other medicine in our world we've stolen from oncology or from, Plaquenil is an anti-malarial drug, so we stole that from the malaria world. But this medicine was the first drug approved for lupus. It's good for joint pain, swelling, oral ulcers. It can be given as a monthly infusion, which is how we initially started giving it. And more recently, you see the auto injector at the top there. It can be given at home in a weekly auto injection, which is really nice because patients don't have to come to our infusion center once a month. The one side effect I will say of Benlysta is that it is a little bit tough. It's an auto injector. It can cause some injection site reactions, but it's really very mild. So even though it's an immunosuppressive medicine, we don't really see patients who get infections from this medicine, which is in contrast to a lot of our other drugs. The next biologic is Safnello or anifrolumab, and this was also a game changer in lupus in that this targeted a different pathway. This targeted something called interferon, which is the protein responsible for those flu-like symptoms in lupus. When people say they feel flu-like and achy, they go out in the sun and they, have to rest for 3 days afterwards and get that rash on their face or their chest. This medicine directly inhibits that protein, even at 1 dose. So the nice thing about this medicine is it's very fast acting. We don't have a lot of those in the lupus world. People after 1 or 2 doses, it's a monthly infusion. Their skin specifically turns around really within a few weeks. So it's incredible to see that this medicine has worked. I will say right now it is only for joint and rash pretty much. It's still in phase 3 trials for lupus nephritis. Some of the side effects, it is immunosuppressive, particularly viral infections. We saw patients had increased flu and also types of viral, what's called a URI or upper respiratory tract infection, including COVID-19 infections. Next slide. So the last one that I'll talk about, which is already approved, is obinutuzumab. And this was recently FDA approved, and this is for active lupus nephritis as add-on therapy, meaning it's never given alone. It's given in addition to other medicines. And this is a very similar medicine to rituximab, if anyone's ever heard that. But this medicine is actually approved for use in lupus. It's given as an IV infusion. The nice thing about this medicine is that it's long-acting. You'll get 2 doses every 6 months, and then you're done. Now, that's a blessing and a curse because if something were to happen within 6 months, you can't reverse or stop this medicine. So it's in you for 6 months. But it's been proven to be excellent with lupus in the kidney. Next slide. So we'll talk briefly about the emerging biologics, these 3, and I want to spend enough time at the end to talk about some CAR T therapy stuff. So the first one here is Tasacit. Next slide. So this is a dual BLyS APRIL inhibitor, and this is very similar to Benlysta. So the way this medicine works is very similar to Benlysta. It's an injection. I think it's probably going to be a little bit stronger than Benlysta. We'll find out soon enough with some studies here. And just some preliminary data that I'll share with you. So the modified SRI response, we have a lot of acronyms in lupus. This one in particular is just this overall response systemically. At 52 weeks, it was 67% improvement in this medicine versus 32% in placebo. So that's about double the effect size. So it's been shown to be very good at controlling joint pain and inflammatory markers in the blood. Like I mentioned, the Selena-SLEDAI is another acronym, and that is a disease marker measure. So the point here is that there was less disease markers. The physician's assessment of the patient was better. and the blood work was also improved at 52 weeks. Again, safety is always a concern. So that third point there, there were upper respiratory tract infections found in this drug. So this, I think, will be a little bit stronger than Benlysta, because I said before, Benlysta is not very strong, in that, it does cause infections. Right now, it's approved in China, but not yet approved in the US. And I think it's in phase 3 right now, which is the last phase before the FDA considers it for approval. Deucravacitinib, it was a TYK2 inhibitor, and this medicine actually was recently approved for psoriasis, which is another disease in our repertoire. It's an autoimmune disease causing like a crusting rash. So now we're using it to look and see if it helps with lupus. And the nice thing about this medicine is that it's an oral tablet that you would take daily, and we don't have a lot of those in lupus besides Plaquenil. So this medicine is easy to take. It's a tablet form, and it does really 3 things. It decreases interferon, which is that protein I mentioned that can cause fevers and chills in lupus and causes a rash in lupus. Also an IL-12 and an IL-23 response, and that's just another inflammatory pathway that it's targeting. When we looked at response in our lupus patients, we looked at 3 things. The first one is called the BICLA, which is kind of the overall response in our patients, and this drug did very well. We looked at the CLASI score, which is a score of cutaneous lupus on the skin, and also this drug did very well. And then overall lupus low disease activity. So looking to see that patients had a very low disease activity at different time points. And it also met all those markers as well. So it's good, we think, for probably skin, inflammation in the blood, and significantly helping the joints. TBD, it's not yet approved. So we're hoping here in the next few months. So now I want to talk about CAR T therapy. And just a show of hands, who has heard of CAR T therapy before? I get a lot of patients who come in and they want to only talk about CAR T, which is great. So I'm glad that the word is getting out. I want to do a little bit of a deeper dive and talk about what this means and what the process is, because we are doing trials here at the clinic. So CAR T therapy it's called an immunotherapy or a cell therapy, in which we take your own blood, so a patient's own blood, we sort it out, and we engineer your cells and put them back into you. So it's almost like akin to a stem cell transplant, in that we're taking your body's own machinery, modifying it and putting it back into you. It is not the same as a stem cell transplant, but the fact is you're using your body's own cells. So basically what we do here, we'll take your cells outside of you and we engineer them to express a specific receptor. And then when we put these cells back into you, that receptor can find the lupus causing cells and kill them. So it's a very, very exciting new treatment. It was originally developed for lymphoma, leukemia, and childhood cancer. So we're really stealing this from the cancer world. It's worked so well in that sphere. It's actually approved in the cancer world. So if you Google CAR T therapy, you'll see things like lymphoma, leukemia, multiple myeloma, and just now it's reaching our autoimmune patients in clinical trials. So the process here is as such. It's a very complicated process. So first, when a patient comes to see us, we talk about CAR T therapy and we say, you have to get washed out of your medicines that you're on now. After you've washed them out now, and of course, there's a risk of a flare, we have them do what's called apheresis, where we isolate the patient's white cells and sort them by the different types of white blood cells that they have. Once we do that, we send them off to a lab that transfects them with a virus, something called a lentivirus, which is something that we do actually very commonly in this space. And we insert a new receptor onto their cells, something called the CAR T, so the actual T cell receptor. We then expand them in a lab and they get sent back to us. So the patient comes in, we give them chemotherapy for 3 days just to make sure that their bone marrow is kind of reset, and then we give them back their cells that we've produced for them. And then we wait for about 2 weeks. And the reason we wait is because there's a lot of things that can happen in those 2 weeks. So you're at risk for infection because we've given you chemotherapy, but also we've given you a new product back into your system. So patients are usually admitted to our bone marrow transplant unit, where they sit for 10 to 14 days. Most patients do very well. They're bored for 2 weeks and they're just kind of sitting around. But in some cases, there is a side effect. Next slide. And this is something that we don't talk about very often. I think people see the results of these trials that we've done in people who are in drug-free remission and doing very well. And that's great when that happens, but it's not at a risk of what's called cytokine release syndrome and something else called ICANS, which is a neurotoxic syndrome. Oops, let's go back. So the left here, cytokine release syndrome, what is this? Well, when we give you back your cells, there's a lot of inflammation that's happening at the cell level. And that can cause, low blood pressure and fevers and chills, and patients can get very sick. It's almost like a graft versus host response. Your body is rejecting the cells that we're giving them. So commonly we'll see patients have a little fever, have a little hypotension or low blood pressure, and that's okay. Sometimes we can expect that we're giving you, new cells and a new product back into you. We can treat them and reverse them. That usually happens within the first 2 to 5 days of getting the cells back. The more concerning thing is the thing on the right here, which is called ICANS. And that is when the inflammation happens in the brain. And patients can have seizures, they can be delirious, they can be agitated, they can be confused. Does not happen often, but of course there's a risk of it. We've done 7 patients now with CAR T, and I've had 1 who's had an ICANS, 2 that have had an ICANS response. 1 was severe and 1 was not severe. We treated it, we reversed it, and the patient did fine. But the point is, these are not uncommon. So this is the big talking point when patients come in and want to be considered for CAR T, because there's an excellent benefit if it works, but it's at the risk of these side effects. So I want to talk briefly about our 3 patients, and this is all with permission. The first 3 patients that we did this CAR T therapy on, the first one was a 30-year-old female, had lupus in the kidney, lupus in the liver, bulky lymph nodes from her lupus, terrible arthritis, discoid lupus. And she was a 5+ year patient of mine. She lived locally in the Cleveland area with her partner, and she hadn't ever worked because she was so depressed and had so much fatigue. The second patient is a 27-year-old female who also had lupus in the kidney. She had terrible arthritis where she had deformities, the Jacquard arthropathy, which is a type that we see with lupus. She had very bad skin lupus on her face and also effusions in her lungs. She was also enrolled based on her kidney disease. And this patient was complicated. She came from West Virginia to see us. She had really wanted to get pregnant, and we finally got her pregnant, and she had this beautiful baby. And right after she delivered, she flared. We know, patients flare a lot after estrogen shifts, including delivery. So, complicating factors were that she had an infant at home. She was coming from West Virginia. She was very sick, and frankly, she didn't have a lot of our options. She had been through all the medicines that we use for lupus, and this is really our last ditch effort. The third patient was a young male who had lupus in the kidney as well. He had really bad heart disease. He had skin lupus, and he had lost a lot of his hair because of his skin lupus. He was in the middle of college, which made it very complicated. And he was enrolled based on his kidneys as well. And he had to come from over an hour away. And like I mentioned, he was trying to do online classes. So there was a lot of complicating factors there. Okay, so this is our first patient. And this is when I first saw her, these pictures. So you see here on the upper picture, that's her mouth. And there's just sores all over her mouth, all over her tongue, all over her cheeks. You see there in the middle that she has what's called discoid lesions. So she has skin lupus on her scalp, and it's causing destruction of the hair follicle, which is causing the baldness. And then on the bottom, you see that she has lesions all over her face. So at the 3-month mark after CAR T, her hair has grown back and her face looked beautiful. The more important thing, though, I think, is that her fatigue and her mood improved markedly. She wanted to go back to work. She wanted to work. She didn't want to be on disability anymore. We reversed her disability status. She finally went on a vacation with her wife for the first time ever. And those are things that we don't capture in our markers for lupus. The blood work doesn't tell that story. So I think that she's really an amazing story in that, she's a different person when I see her now. She's not falling asleep on the table. She's not kind of depressed. She has a job, she has a life now. And this treatment has really given her life back. This is a second patient that I mentioned who had just had a baby. You see here on the upper right, this was during COVID. She had lost most of her hair after she delivered. She was very, very skinny. She had a pink rash on her face, which you can't see because of her mask, and her kidney disease was flaring. Next. That's okay. So the picture here on the bottom right, this is the day after she's gotten she had finished her hospitalization for her CAR T. She was doing very well. Her rash on her face was significantly better. I don't know if you can tell in that picture. And of course, her baby was finally allowed to come and see her in the hospital. This is the last patient who I believe was one of our sickest. On the left here are the before pictures. So he had rash all over his face and his scalp, which you can't see, also on his neck, and he was very swollen. So the bottom left picture, he was in what's called nephrotic syndrome. So his kidneys were spilling a lot of protein, which makes people very, very swollen. And he felt terrible. He could barely attend his online classes. 3 months later, on the right, you see his skin has cleared, not only on the face, but also on the neck. And he's much less swollen on the bottom right. He is since about to graduate now, and he wants to go into biomedical engineering. So I like to think that this kind of convinced him to go into that, but I'm not sure that's the case. So like I mentioned, patient one, now it's been 27 months from therapy and she's doing very well. She's working again. That second patient is also doing great. She wants to have another baby. And the third one, like I just mentioned, he did relapse in his skin. So he is the only one that is back on therapy of our 7 patients. So he's the only one who is not in a drug-free remission, but everyone else is at this point. Any questions?
Thank you, Dr. Littlejohn. Do we have any in-person audience members with questions?
So that last medication, that's a one-time deal usually?
The CAR T therapy?
Yeah.
For right now, we think so. Yeah. The
Wow.
longest data that we have is people have been in remission for 4 full years.
Wow.
So yeah, but not everyone is in remission. It's just the people who've done well have done well for 4
And they're
years.
on no other medications after that?
Some of them are, but they're very few. Like I mentioned, our last patient here, he still does get a medicine for his skin, but it's nothing like what he was taking before. You know, as you all know, patients with lupus take like six to 8 medicines.
At least.
Yeah, that's like the average data. So yes, they're doing very well.
I love the chuckles when everybody hears 6 to 8 and we're like, we're 20, you
Yeah.
know. Yes.
Oops. It looked like the studies, it was all younger, well, in relation to younger adults. Have there been studies in older adults?
In these CAR T patients, this is just 3 that I picked out of our group. Usually it's 18, I think, to 64 that
Okay,
they've
so
done
there
them in.
are-
So most of the patients are younger, and the reason is that they've failed all the drugs. So most of the people who get enrolled in these trials have no other options. So they very quickly cycle through all of our medicines. So it'd be rare for someone to have cycled through everything and then flared towards the end of their diagnosis. And most people get diagnosed young, but there are older people who can be in these trials. Right now, we're enrolling people who have very severe disease with active organ involvement, despite all of our treatments. So you have to be, you know, pretty sick to be getting them right now, just because we're still in phase 2. So
Other in-person questions for Dr. Littlejohn? Okay. Alex, do you have any coming in? Okay. I had some pre-submitted questions that I will ask. People were asking about the biggest side effect complaints from biologic therapies. So what do you hear the most? Is it infections? Is it?
yeah, infections is probably far and away the most. Like
Okay.
I mentioned, with the exception of Benlysta, which is really not, doesn't put people at risk for infection. But yes, infection, particularly viral infections, because the way these work is that the pathway is usually the one that helps us find viruses and bring them down.
Okay. Do you hear much about UTIs? I have heard patients talk about UTIs with the
It's certainly
biologics.
possible.
Okay.
I mean, patients have, you know, recurrent UTIs also for other reasons, and this would only make it worse if they are at risk for those things. But that's
Okay.
not one of the ones I see, but
Okay.
it's possible.
I know the person that asked that. I know.
Okay.
That's a problem. That's why I brought that up. Okay. I've heard a lot of talk in the lupus community about combination therapy with biologics. Can you tell me what that means?
Yeah, we do that more often than not, actually. So most of those medicines that I presented that are not approved can be used as add-on therapy to what's called standard of care, or tablets that you're already taking. So every medicine should first of all be an add-on to Plaquenil, like we mentioned. So that's a combination right there. But some of these are given alone, like anifrolumab we can give alone. You'll always be on Plaquenil as well if you can take it. So most of them are combination therapies. Yeah, it's very rare that a patient is on a biologic alone.
Okay.
That would be the minority.
Sure.
Mhm.
Okay, great. Now that there are multiple biologic therapies for SLE, how do you, as a physician, determine which one the patient should take?
So unfortunately, I only really have 50% say. Insurance companies dictate a lot of what we're able to give. But that aside, I think, Plaquenil is number one. Everyone should be on that. It's not a biologic. The next biologic is Benlysta in terms of strength, and then anifrolumab. So it's all about what symptom patients have. If they're very sick with severe organ involvement, we're going to go to a stronger medicine first.
Okay, that
Yeah.
makes sense. I wrote down one as you were talking about CAR T. Are they trying to get to a point in the CAR T therapy world of making it so that it is less of, I know there's like a hospital stay and you're severely depleting the immune system. Are they getting to a point where they're kind of going to make that a more mild version so that patients maybe with like non-severe refractory disease can take it?
I think that's what they'd like to do, but we don't have data to prove it's even helpful in patients who have, as you could see, the risks and side effects are so severe that we wouldn't want to give it in someone who, only has a mild case of lupus, because we
Right.
don't know what will happen to them. The risk benefit is off. I think it's going that way. They've really liberalized the inclusion criteria who they're letting in these trials. It used to be the sickest of the sick when we first started doing this 2 years ago. And now it's like, well, if you've been sick in the last year and you can actually probably stay on some of your meds during the therapy. So we're getting into a space where people don't have to be organ threatening, life threatening disease. But we're not there yet.
Okay, got it.
Yeah.
We have 2 more questions. Barbara?
Has this been studied long enough to be able to tell, for example, if you've taken one of these, and let's say that was 5 years ago, and your condition deteriorates, can you go back and repeat it?
That's a great question. So we don't have enough data. Like I said, the first people who did this were in Germany in 2020 now. So we really only have like 5 to 6 years of data. But there was some stuff presented at our national meeting last fall, which showed if patients got a special kind of this, they were able to get it again. A little bit different target. So I mentioned we put like a little target into your cell. It's a little bit of a different target that depletes the cells even more. Now that's a little dangerous to do, right? Because you're getting double immunosuppression. It's kind of like getting another bone marrow transplant, right? That's like, wow. But they did pretty well. It's just a handful of patients. So instead of using that CD19 target, which depletes all your B cells, it was something called BCMA, which depletes like your whole memory cells as well. So we're getting there. That's like a hot topic right now in room, what to do.
Did you want to ask a question?
I do have one question. Well, I mean, it's very fascinating. And one question is, what do you do with patients who have overlap disease?
They've been excluded from these trials for reasons because I want to just see just lupus patients, how they do. It does depend on the overlap. If it's lupus with Sjogren's, which many patients have,
Yeah.
lupus with secondary Sjogren's disease, they were allowed in these trials. But otherwise, if they have a true lupus and, scleroderma or lupus and mixed connective tissue, they excluded them because I wanted this to be a very clean trial.
Great. Thank you.
All right, we do have one online question coming through.
It is. Has kidney? Oh, it can make me do. Has kidney involvement been reduced with CAR T?
Yes, all those patients were actually enrolled based on their kidney disease, and they're all in remission. One of them, we weren't sure. We re-biopsied her kidneys, and she's in class 6, which is sort of like a burnt out kidney, meaning it's not active lupus. But yes, actually all 3 of those patients had kidney disease. Of the 7 we've done, I think 6 have had kidney disease. So yeah.
Great, thank you. Oh, one more, sorry. Keep sneaking up on me here. Is that Heather? Is that you? No, oh, it was Brenda. It's Brenda. Hi, Miss Brenda.
Hello, I was just wondering if you were on a biologic, say it doesn't work and you get a different one, how long do these monoclonal antibodies stay in your system? Do they fight with each other? You have to wait for them to clear out?
How long can you have to wait? It depends. So for example, Safnello or the anifrolumab infusion lasts for a full month. And then we think that it dissipates. I usually give patients 3 months for the medicine to really get out of their body. They don't really fight for each other because they're targeting different areas. So I wouldn't put you on a medicine that's the same exact target. So in that way, it would be out of your system within probably 1 to 3 months. That's a good question. They do hang around for a little while. And, I just want to remind everybody, biologics are great, but there are a lot of really good medicines that are not biologics. For example, methotrexate is not considered a biologic necessarily, but methotrexate enhances the effect of all the other meds that we put you on. So if you're on methotrexate with CellCept, it's going to increase the efficacy or the usefulness of the CellCept. So there are other meds besides biologics out there. We're just focusing on them for this talk.
Okay, great. Thank you, Dr. Littlejohn. Let's give her a round of applause. Okay, Dr. Littlejohn has to head out. She's on consults today, so thank you so much. We appreciate it. And while we get, I think we're going to get Dr. Wasif. Do you have the microphone? Yeah, I'll give her mine. Okay, let me introduce her really quick. So our next speaker is Dr. Hiba Wasif. Dr. Wasif is a clinical cardiologist and director of inpatient clinical cardiology in the Tomsick Family Department of Cardiovascular Medicine, Seidel and Arnold Miller Family Heart, Vascular, and Thoracic Institute. That's a mouthful. She is also faculty at the Cleveland Clinic Lerner College of Medicine. Today, Dr. Wasif will speak about preventative cardiac care in SLE. Thank you so much.
Thank you. Well, thank you everyone for coming today, and hopefully this will be a bit educational, a very different shift from what Emily had talked about, which I learned quite a bit even sitting there. Next, so we'll be talking about one. I mean, I'm speaking to a crowd that knows this, but I do feel like it's important to know how common lupus is. I'll also describe the cardiovascular risk and how to evaluate patients who live with lupus for cardiac conditions. And when we think of cardiac condition or cardiovascular risk, we're always thinking about coronary artery disease, but there are other aspects of cardiovascular involvement with lupus beyond the coronary arteries, and I'll touch very briefly on valve disease and heart failure. So we talk about inflammation, and this has been over the news for many, many decades. I mean, this is Time magazine from 2004, scientific publications talking about inflammation. Next, and the ACC just produced this scientific statement last fall on inflammation and cardiovascular disease, and I was very pleased that there is a movement from our society to acknowledge the presence of this very, very strong link between inflammation and cardiovascular disease. Inflammation has many aspects, and many things that we are seeing in our environment contribute to inflammation, and they also contribute to inflammation with lupus, as I will discuss shortly. So smoking, dyslipidemia, what we eat in our gut, like microbiomes, like they produce certain products or molecules that contribute to inflammation, so particularly something called a TMAO. Organism or rather molecule that adds to inflammation. Perivascular fat, it's the fat around the coronary arteries. Vascular adipose tissue, fat under our skins. Diabetes, clearly, and many other factors that contribute to active species. But the big issue is autoimmunity. Next, and autoimmunity is a very broad spectrum of disorders. We've heard about the overlap. There's many overlap disease. They range between inflammation and autoimmunity. Clearly, lupus falls in the autoimmunity aspect of this very broad spectrum that includes over 100 disorders. Next. And it's present all over the globe, and there's a lot of variation of how common lupus is. You see all these purple areas around the globe. There's no real information about them, and we look at the United States, and there's clearly a gray area where there's a lot of variability between communities, ethnicities, on how many patients suffer from lupus. But on average, we say it's about 72 individuals per 100,000 population. So it's not a trivial component. It may be higher in like southern areas on certain ethnicities, but it's important to keep that in mind. This is data mostly from administrative data, so the numbers are much higher in terms of the prevalence. We're seeing numbers that are reaching 188 or even 272. Some of them are self-reported, so I doubt some of their accuracy, but these are all per 100,000 population. Again, the numbers are not trivial. But what we're also seeing is that there is rise in lupus over the last 40 years. So this is data from Mayo that was extrapolated to the general population. And we can see that the numbers have increased across all age categories. So it's not a disease of the young, it's also a disease of middle-aged and older patients. So it can happen at any point in our lifetime. Unfortunately, women are more affected than men, 9 to 1. We all are aware of that. And I always had asked myself the question, why are women more affected than men? Clearly, our gender hormones, our sex hormones play an important role. We can see all these green dots. These are estrogen that combines to estrogen receptors that affects the cellular transcriptions, and that subsequently leads to the increase of the autoimmunity. There is another theory that has been published recently, that because women have 2 X chromosomes and one of them is somewhat inhibited to avoid duplication of proteins, the proteins that are used to inhibit that chromosome form complexes that promote autoimmunity. Again, these are more theories, again, trying to understand why are women more affected than men with these disorders in general, not only lupus. The spectrum of cardiovascular manifestations for lupus is very broad. I say from like plaque to pericardium. So the vasculature, accelerated atherosclerosis, but also the small vessels of the heart, microvascular disease, which I will discuss, valve disease. It affects the heart muscle. It affects the lining of the heart. One of the patients that Emily had presented had a large pericardial effusion. It was the last patient. So the lining of the heart that can lead to accumulation of fluid. And then some of the treatments that are used for lupus can potentially also cause weakness of the heart muscle. Not common, but it can hydroxychloroquine that has been mentioned, which is a mainstay in the treatment of lupus. So it's very rare. We suspect it a few times, but we don't have, I mean, it's not something that thankfully we don't see it every day, since it is a very important treatment for lupus. Also it affects the conduction system and arrhythmias. Next. This is one of my favorite quotes, is that the eye sees only what the mind is prepared to comprehend. And the patient that I'm presenting was truly an eye opener for me several years ago. Next. This was a young woman, 38 years old, who had history of marijuana use, asthma, family history of premature coronary artery disease, who presented with an acute heart attack. So she had a heart attack in the big blood vessel in front of the heart. Next. She clearly, because it was an acute event, she underwent catheterization, and we found that she had a blocked artery. We see that cut off. There's no blood supply going through. So unfortunately, this is not playing. Next. And she ended up having 2 stents and did well. But as we do when somebody suffers from a heart attack, we wonder, what are the causes for the heart attack? What are the things that we can change? How can we do secondary prevention? And one of the things that we look at, obviously she had some family history, but she really didn't have any glaring risk factors. She wasn't diabetic. She wasn't hypertensive. Her lipid profile, some abnormalities, but nothing that was outstanding that would contribute to this degree of disease in a young woman. And when we dug history and further into her history, it turns out that she was having hair loss and she was having some skin manifestation, and was shortly after diagnosed with lupus after this event. So what are the risks of cardiovascular events with lupus? It's clearly not trivial. And this is an amalgamation of studies, something we call a systemic review and meta-analysis that included about 14 studies. Over a million patients were included. This not of lupus, just in general, patients with coronary artery or patients with lupus and rheumatoid. Next, and what was found with this meta-analysis, that the risk of a cardiovascular event in patients over the age of 46 was almost twofold of that of the general population. And in younger patients, the risk was even higher. And that has been reported even back to in the mid-90s. There was one study that had also reported that the risk can go up to 50%. So, and this may be related to like a very aggressive disease in young patients. Next. This is work that we had done with one of my residents, because we asked the questions like, since cardiac care has improved so much over the last 20 to 30 years, what have we done? How does that pertain to patients with autoimmune disorders? So we reviewed the CDC multiple causes of death database over the last 21 years, and there were 300,000 deaths in patients with rheumatoid, lupus, and systemic sclerosis. But as you can see, the curve goes down from 1999 to 2020. The top are female, the bottom are male, and we can see that the crude mortality, people dying from heart attacks, was becoming less, almost like 4 per 100,000. It was almost 2 for women, and it was 1.7 and became 1.2. And on the right-hand side, these are adjusted mortality, meaning adjusting for their other medical conditions, not just the pure mortality rate. But what we clearly see, yes, the mortality had decreased, but women remain disproportionately affected by or increased risk of mortality compared to men. And this garnered a lot of national attention. Next, and a lot of headlines, women with common autoimmune disorders face higher rates of death. And I was asked the question, like, why was this happening? And this was more, the study was more to understand what the trends are. It doesn't give us explanation why the trends are, but some of it is recognition of cardiovascular disease, also recognition of symptoms, recognition of different treatments, but that's not what the study was intended to do, but that's why we're bringing awareness to cardiovascular disease in community. It's not only the big blood vessels that are affected with autoimmune disorders, including lupus. We saw the big blood vessel that was blocked, but we have acres and acres of small blood vessels called the microvasculature. You see all this like small web of blood vessels. That's actually, that can also be affected with inflammation, where the lining of these small blood vessels doesn't perform as it should, and patients can have pain and symptoms and even heart attacks, a condition we call INOCA. Next. And women, and this was a study was done by a colleague of mine when she was at the Brigham, where she looked at the flow of blood through these small blood vessels and how is that impacted in lupus patients. It was a small study. There were 40 patients with lupus and 60 patients without lupus. And what she found was that patients with lupus, the blood flow, or what we call, in other words, and I'm simplifying it, it's something called the myocardial flow reserve, which is a ratio between flow at stress and flow at rest, was impaired, and it was low in women with lupus compared to patients without any autoimmune disorders, even if they have blockages. So it clearly is a separate problem than the big problem of blockages, but still remains a problem. Next. And this also, building up on that work, patients with microvascular dysfunction can also have lower survival compared to others. Next. So why is this happening? Why are patients with lupus and autoimmune disorders disproportionately affected with coronary artery disease? As Emily was discussing, there are lupus-related risk factors, the systemic inflammation, lupus nephritis clearly plays a role, autoantibodies, interferon alpha, the lipid oxidation, but there are also the traditional risk factors that contribute to cardiovascular disease that are also somewhat different in patients with lupus, and I'm going to discuss that. But for the interest of time, I'm just going to focus on hypertension, dyslipidemia, and smoking. Next. There's a very high prevalence of hypertension among patients with lupus. Some of the studies are noting up to 70%. So it's a very, very important point, that part of the lupus care, that we pay attention to the blood pressure. And there's many reasons why people suffer from hypertension with lupus. Clearly, lupus nephritis is a problem, but also some of the medications that are being used. We've heard Emily talk about the glucocorticoids, the steroids, also one of the side effects. It can also increase the blood pressure. I'm glad that we're not using them as often. There's upregulation of certain neurohormonal aspects that contribute to hypertension, something called the RAS. There are cytokines, there are insulin resistance, the endothelial dysfunction, dysautonomia. So there are many, many different pathways that lead to, at the end, it increases the blood pressure. So what happens? So why are we so focused on high blood pressure? Well, it's important because it does increase events. And this was a very nice work that was done at the lupus, actually the cardio room program at the University of Toronto, where they followed about 1,500 patients with lupus for 2 years. They had information about their blood pressure, and then they had outcomes that were reported about 10 years out, or on average of 10 years. And what they found is that patients with a blood pressure that's higher than 140/90 had more events. Almost, if you followed 1,000 patients for 1 year, they would have 20 events, compared to people or patients who had blood pressure controlled to less than 130/80. Because many of us think, oh, 140/90, that's pretty normal. That's not a problem. Why should I worry about it? But it is a problem because there are more events, even at that very low, or what is considered low, low blood pressure. And the next slide, please. We see this very well in the green, that patients who had a blood pressure less than 130 over 80 had much lower events compared to somebody who was with a blood pressure of 140 over 90. Even though the difference is not huge, the events were much lower. They were almost 4 times lower. So that's why it's very important to, as part of the lupus care, to look at the blood pressure. Next, unfortunately, or maybe fortunately, only 15% of rheumatologists did not check blood pressure at every visit, but the majority did. So it's a very important component, as I said. But only half the rheumatologists have recommended blood pressures to be less than 130 over 80. But again, there's increasing awareness of the importance of blood pressure. The next important aspect of reducing cardiovascular risk is addressing dyslipidemia, and Emily touched on that briefly. What do we mean by dyslipidemia? Dyslipidemia means that there is an imbalance between the good cholesterol and the bad cholesterol. So the bad cholesterol is high and the good cholesterol is low. So the HDL is down, the LDL is high. And it's very common among lupus patients, reported up to 30% within 3 years and almost 60% thereafter. Some of the medications can contribute to that. Plaquenil does improve this pattern. Next. There's a very interesting phenomena in regards to lipids in patients with autoimmune disorders. It's been well described in rheumatoid arthritis, but we have found that also in lupus patients. We haven't published that data, but we have found it. It's something called the lipid paradox. What does that mean? What it means is that when the disease activity is low, as we see on the orange graph on the bottom, the lipids actually go up. And when there's flare, the lipids actually go down. So it's not a good idea to be checking lipids when somebody is having an active flare, because they may be erroneously low, and one would think, oh, the lipids look great, we don't have to do anything. But it's mostly because of the flare that they are erroneously low. They're not erroneously, but rather they are low. So what do we do with lipids? Well, the lipid guideline, the dyslipidemia guidelines, were just released like within this last month. And across the board, whether with autoimmunity or non-autoimmunity, there have been an increased focus on reducing the LDL targets. We're really advocating that they be less than 100 for people who don't have any other risk factors. And for patients who have risk enhancers, will probably be closer to 70. They also introduced one of the newer risk models called PREVENT. I will mention later on this talk, and also introduced the calcium score for reclassification. Next. And they also introduced, and they actually is one of my mentors from Hopkins and his colleagues, the concept of CPR for dyslipidemia, where you calculate the risk, you personalize it to the individual, and you reclassify with a calcium score. Next. And clearly in patients who have very, very low risk, lifestyle modification is important, make consideration to the statin if their calcium score is high. But if you have very high cholesterol or very high LDL, it's very important that you be on lipid management. But are we doing that? And granted that the data that I present is before the dyslipidemia guidelines were released. This is next. This is the work that we had done, where we looked at administrative databases at 41,000 patients with a variety of autoimmune disorders, and we compared them to diabetes. And the reason we compared and assessed how do they use statins, and the reason we use diabetes as a comparison is that diabetes is the equivalent of having coronary artery disease. Patients with diabetes are at very high risk of cardiovascular disease. And what we found, which was very surprising, that patients with autoimmune disorders, even at very high lipids in the 160s and 190s, the prescription of statin was very low, less than 50%. So this is another important area where improvements in care can be made. And lastly, We'll talk about tobacco and tobacco use. Smoking in itself increases the odds of developing lupus, and patients with lupus who smoke have also increased risk of flare of the disease, particularly Raynaud's. And obviously patients with lupus and who are smokers have increased risk of developing cardiovascular disease. So it is an additive effect. So I mean, we think, okay, well, you know, I can control one factor or another factor. So what does it matter at the end? Well, it does matter at the end, because the more risk factors you control, the more likely that your risk goes down and will be compared to somebody who doesn't have any autoimmune disorder. And this is a great study that was published from Greece, where they looked at patients with lupus and compared the amount of plaque blockages in their carotid arteries. And you see in the red line, it's clearly higher than healthy people. But when you control risk factors, if you have one risk factor that's controlled, the risk is lower. 2 risk factors, it's even lower. If you have 5 risk factors that are controlled, it almost approaches the norm, the general population. It's never going to be 0, but you are reducing your risk. And I cannot finish a talk or discuss cardiovascular risk and prevention without discussing the role of exercise. Regular exercise, extremely important. It has an impact on obesity, hypertension, diabetes, dyslipidemia, and eventually mortality. Next, and there are new guidelines, or actually a consensus statement that was released by an international task force for physical activity in lupus patient, really advocating for exercise with not during the flares, because you don't want to have any joint injuries either, but with discussion with your physician. And if you feel that you're able to do it, it's highly advised to exercise. Next. So I've talked about the risk, and I've talked about the factors that contribute to the risk. So how do we measure this risk? And you see from this extremely busy slide that there's so many different risk calculators. There's a Framingham, modified Framingham, ASCVD risk, Q risk, predicts, SLE, CRE, the adjusted global antiphospholipid score. And then also now we have the prevent that was introduced in the dyslipidemia guidelines. In other words, none of these are perfect. We have many different ways to assess risk. Some of them include disease activity, so they do better or they perform better in predicting risk. So for example, the Q risk is a risk score that includes the diagnosis of rheumatoid and lupus and steroid use, and is very widely used in the UK. My colleagues in the UK tell me that that's what they use. They don't use anything else, none of these risk calculators. But more important, which is what I use also in my practice next, is imaging. So what do I mean by that? There are so many different imaging techniques, but what I mean specifically for coronary artery disease is a coronary calcium score, which was also highlighted in the dyslipidemia guidelines. Next. A coronary calcium score is estimating the amount of calcium in the coronary arteries, and we use that as a surrogate for pre-existing coronary artery disease. And this is a study that was done in Denmark, where they have national data. 85,000 patients who underwent a coronary angiogram, and they calculated also the calcium score. And there were 4,000 patients in this group that had some autoimmune disorder, including lupus. And what they found, and this just confirmed many, many other studies, except that this was a larger study, that patients with autoimmune disorder had a higher risk of having coronary calcium score. The likelihood of their coronary calcium score being over 0 was almost 40% higher to people with not. In other words, which is what I said, that there is increased risk, and the calcium score does help to assess that risk. And I use it very frequently in my practice when I'm trying to assess, is this patient low risk? I obviously ask about risk factors, how long the disease activity was, and if, depending on the situation, I may or may not opt to using a calcium score for risk classification or risk reclassification, but it's extremely important to address the risk factors that reduce cardiovascular events. I just want to move on from coronary artery disease, and I want to talk about valve disease. And this is a patient that I had seen in clinic, and I still see her in clinic, a 28-year-old woman who's much older now, with lupus and lupus nephritis and antiphospholipids, who presented with a stroke at that time. She clearly, we see that stroke on her head, on the brain CT. And when they did her echo next, they found that she has, unfortunately, this is not playing very well. Can you click kindly? No. She had severe, if you click maybe on that one, no, okay, well, not a problem. So she had valvular disease related to lupus. So the valve was thickened and not moving, and there was a lot of regurgitation from that valve. She was referred to my clinic to address the valvular disease. She was on significant immune suppression at that time, and we followed her, and she eventually underwent surgery successfully and did well. So how often do we see valvular disease in patients with lupus? Next, it's actually not uncommon, especially in patients with lupus anticoagulant, approaching almost 1 in 5 patients, particularly in the lupus anticoagulant patient. So again, annual exams are important. If there's any suggestion of a murmur, an echo will be warranted. Next. And I just wanted to bring this one. This young patient had presented with a stroke. So just because somebody is young, we should be mindful of what the mnemonic for stroke being fast. If there is any suggestion of a drooping arm or face or speech difficulty, time to call, just address it right away, regardless of the age. And then I will end with the risk of heart failure, which is not also trivial in patients with lupus. Next, heart failure is an independent risk factor for almost 5-fold. Lupus is an independent risk factor for heart failure, almost 5-fold risk, and that's regardless for men and women alike. And in my mind, I consider it what we call a stage A, meaning that you are at risk because you have lupus. Addressing the risk factors are very important. Next, this is work that we also did a few years ago, and we found that patients with autoimmune disorders tend to develop heart failure earlier than their cohorts, and about 5 years between autoimmune and non-autoimmune patients. Next. In other words, patients with autoimmune and particular lupus at an increased cardiovascular risk, different parts of the cardiovascular system. Next. It's only the tip of the iceberg that our knowledge is still limited. There are many mechanistic things that we can interfere on. This is an area of a lot of active research and collaboration. And that's why this new model has been introduced in the last few years, where I collaborate with Emily and my other colleagues in the rheumatology department, where the rheumatologists interact closer with the cardiologists as well as primary care for care. So it's not care in isolation. So next. There are some cardio centers around the country, but they've been increasing dramatically over the last few years. The slide is maybe a couple of years old. Next, there's also active research. As I mentioned, there's this international study that's enrolling for, it's not a therapeutic trial, but it's more of trying to understand what happens to patients with autoimmune disorders when their heart is affected, when their pericardium is affected, and so forth. So it's garnering a lot of attention, as it would deserve. Next, and I thank you so much.
Thank you, Dr. Wasif. That was a lot of information. And, I think the thing that stands out to me most is we really have to take care of our hearts and our blood pressure and all the things involved. So appreciate it. Anybody in the audience have questions for Dr. Wasif? Okay.
Yeah, I just wanted to know, did you mention anything there about people with low blood pressure for lupus?
Low blood pressure.
Did I miss that?
No, I didn't talk about low blood pressure.
Okay.
That I did not. I talked about hypertension because that's more common.
Well,
So-
is that some kind of a sign for anything?
Well, low blood pressure, I mean, what is defined low blood pressure? Because many patients are living, with a blood pressure of 100 and they feel fine. They're not lightheaded. They're having no symptoms. There's no dizziness. That is their normal blood pressure, even though it may be on the lower side. But if you're having no symptoms, that is not a disease by itself. The lower, the better. But if your blood pressure is low and you're feeling lightheaded and dizzy, that's a whole different story. When we were using steroids, you could have adrenal insufficiency, but obviously now we're not using as much. Could there be autonomic dysfunction? There's a possibility, but it would not be just low blood pressure in isolation. Infection would be something that would be concerning if somebody has a normal blood pressure and then all of a sudden their blood pressure is low. So you have to think about infections.
Thank you.
Of course.
Okay, anybody else in the audience have any questions for Dr. Wasif? Okay, we do have, do you want to? Okay, Alex is calling me over. It looks like we have a question.
All right. This is a long one, but what about people who don't suffer from HTN and have increased lipid levels with low activity of flares and don't suffer from diabetes and do not smoke? How are those patients treated with preventative cardiovascular care with SLE?
That's a very good question. As I mentioned, you address each risk factor as they are. If you don't have hypertension, that's great. That's one less thing you have to deal with. If you have a flare, you don't want to injure your joints. You end up with more problems than not. The dyslipidemia in isolation needs to be addressed. And so you won't improve your HDL because you won't be able to exercise. But if you control the LDL, whether it's with medication or changes in diet, depending on what the risk is, it's very, very important.
Okay, one more from our at-home audience.
Are any particular valves more likely to be involved?
That's a very good question.
Great question.
It's usually the mitral and the aortic valve.
Okay,
Yeah, and in this patient, it was her mitral valve.
do you have any others? Okay, we have a couple pre-submitted questions for Dr. Wasif. My doctor wants me to reduce my cholesterol. I'm doing everything I can, but it still won't go down. I exercise, eat right, get sleep, etc. Is it possible my 5 milligrams of daily prednisolone, I can never say that, prednisolone, is causing my high cholesterol? She wants me to start on a statin, but I'd prefer to get it down on my own.
It depends on what level we're talking about. If the level is really quite high, lifestyle may cause a reduction 20 to 30%. It probably would not bring, but if you need to half it or more, it's probably not going to be just by lifestyle.
Okay.
So if your cholesterol is the bad cholesterol is over 160, that will not come down just with lifestyle changes. It will have to be a statin therapy because there's probably a genetic component that's adding to it as well.
Gotcha. Okay, great. One more question here. I'm worried about heart disease because I have lupus and high cholesterol runs in my family. Should my doctor do any screening? I am a female, age 42.
I think it's reasonable to consider a calcium score. I don't think that to reclassify, because if you calculate the risk, it probably will be more in the borderline or the intermediate risk category where, it will be advisable to reclassify using a calcium score.
Okay. Do you recommend, this is me just after that question, do you recommend a certain age or a certain time period in which a lupus patient should just go see cardiology to make sure everything's okay?
It's a very good question because I don't have a very good answer for it, because the rheumatologist really is the person that guides the ship.
Right.
And the EULAR, the European League, they're recommending that the rheumatologist kind of address the risk, and if the rheumatologist feel that the risk is high, then they need to be referred to cardiology. Obviously, the earlier the better.
Okay, great. Thank you. Oh, one last question from our audience.
Hello. Hi. I've been diagnosed with lupus since 2018, but the flares that I've had they're all different, right? So then I'm noticing like with my heart, like something different, but it's kind of like hard to explain, or it's more like an intermittent thing. So would you go get something like that checked and state that you have lupus, or does your rheumatologist have to, assess it and tell you to go see cardiology?
I mean, if you're saying I'm having palpitations or I'm having chest discomfort, I think that's where the cardiologist will need to be involved. I think what I'm talking about, the risk, I'm talking about the risk of cardiovascular disease, like assessing when they need to be referred.
Okay.
If the risk factors are all not controlled and somebody's doing poorly, I mean, that would be a good idea to refer to a cardiologist.
Okay.
I think if you have,
But
you have
you're having
symptoms, you go.
symptoms, that's a whole different aspect. Here, we're just talking about prevention.
Yeah, great. Okay. One more online question.
All right. Could SLE contribute to supraventricular tachycardia?
I don't think, there's like a clear link or data that I am aware of. I'm thinking because anything, there's been a very large study from the UK that just looked at arrhythmias, not specifically like supraventricular tachycardias, and there's just increased risk, period. Not with lupus, with autoimmune disorders in general. So I can say, yes, that is what it caused, because SVTs are also very common among the general population. Would lupus necessarily increase? It's possible, because there is always an increased risk of arrhythmia.
Okay, great. Hi, Barbara. One more. Sorry. One more.
I don't have a question, but I have a comment on the people asking about the cardiology. Those of you who know me, I just kind of collapsed one night and woke up in the hospital in ICU. And while I was in ICU for 2 months, I had cardiac arrest twice. So when I eventually went home, my heart was pumping at 30% rate. And I found that my doctors, so I had the rheumatologist, the cardiologist, the immunologist, they guided me. I didn't really feel bad. I was very weak. But he says, okay, I'll see you in a month. And then it was like, okay, I'll see you in 3 months. And then it's like, I'll see you in a year. And as my condition improved, the severity of my doctors decreased, because it started out with the head of the cardiologist and then someone a little less and then a little less. But now I'm at the point where they say, well, I'll see you next year, or don't come back for 2 years. And they'll say, well, have a echogram before you come. So I feel fine. And they say, well, if you have a problem, come back. Otherwise, I've progressed to the point of normalcy.
Mm-hmm.
And I don't really worry about it. The doctors are really quite good at telling you what to do. You just have to follow what the doctor says.
That's the bottom line. Yep.
That's good.
What point well taken.
Yeah. If you want to hear more about Barbara's story, she was featured in our last Living with Lupus magazine. So if you get online and look at that, you'll hear her story. All right. Let's give a round of applause for Dr. Wasif. Thank you for joining us. Thank you.
Thank you.
Okay, we're on our last speaker today. Our last speaker is Dr. Laura Provenzano. Dr. Provenzano is a nephrologist at the Department of Kidney Medicine, Glickman Urological and Kidney Institute, and the medical director of the Ohio Home Dialysis Unit at the Cleveland Clinic. Also a mouthful. She is a clinical assistant professor of medicine at the Lerner College of Medicine at Case Western Reserve University. And today she's going to speak about emerging therapies in lupus nephritis. So welcome, Dr. Provenzano.
Good morning. Is it working? Are you guys awake? There was a lot of information. I think, it actually ended being really good how we did it. I think that Emily set the stage. Dr. Wasif put out the main, the cardiovascular risk. And I'm going to go to the kidneys that are not as important, maybe, as the heart, but they are. But you'll see where's the link between the heart and the kidney here. So I did this talk a few years ago, so some of you may have heard it. I'm just going to add on to that. I want to start, and is it working? No? I'm going to start just like to telling you a bit about it, but let's see. You need the thing again? Otherwise, I can email it to you. You want me to email it to you? Because you know, like Adrian, he got the old email, not the last email. Mm-mm. Shall I? Yeah. Well, that's the old one, but that's okay. I'll use the old one. Don't worry about it. It's fine. That's what I told you. I changed it a bit, but we'll use the old one. Okay. All right. Go ahead. So those are my disclosures that are not relevant to this talk. So yeah, the slides might be a bit off, but why we're talking about lupus nephritis? Because lupus nephritis is when the lupus attacks the kidney, and it's actually very common in patients with lupus. Okay, I'm not so sure how many of you have lupus in this room. Is everyone has lupus here? Yes. Does anyone have lupus in the kidney? Okay, but based on what we know, up to 60% of patients diagnosed with systemic lupus will at some point during their lifespan be diagnosed with lupus nephritis. So it's something very common, okay? And of all the what we call severe complications of lupus nephritis is the most common. Again, cardiovascular disease, cardiovascular lupus in the heart, lupus in the brain are very severe complications, but are not as common as the kidney, okay? And as we know, lupus patients are young, mostly are female, so these kidneys get affected early in life. And it's very important that we diagnose and treat this soon, okay? Next. So why do we call it severe? Why is a severe complication? And this kind of brings me a bit back to Dr. Wasif. Because when lupus affects the kidney, many times it leads a scar, okay? And that scar is what we call chronic kidney disease. And having chronic kidney disease is a risk factor for, of course, progression of that chronic kidney disease, what we call end-stage kidney disease. That means when your kidney does not work enough to allow you to survive without a renal replacement therapy, that could be a transplant or dialysis. So this affection in the kidney can lead people to dialysis or transplantation in up to 30% of cases. And chronic kidney disease itself is associated with an increased cardiovascular rate. So once you develop lupus in the kidney, then you have increased risk of heart disease on top of the increased risk that you already have by having lupus, okay? The chronic kidney disease causes some of the risk factors, not just because of chronic kidney disease itself, but if you have chronic kidney disease, you have more risk of having high blood pressure, and then high blood pressure increases further your cardiovascular risk. And with all these, chronic kidney disease, end-stage kidney disease, and cardiovascular disease, hypertension, all of these increase your risk of dying. Okay, so having kidney disease, not for you to get scared because we can treat it, right? But when you have chronic kidney disease or we have lupus in the kidney, we have to treat it soon because otherwise we can affect your overall survival. Okay. When lupus hits the kidney, the treatment is long. Okay, we're talking about 5 years of treatment at the minimum, ideally. And that treatment, at least based on the stage today, means a lot of toxic medications. I mean, that help you, but cause a lot of side effects. Steroids cause weight gain, diabetes, hypertension. All of them affect cardiovascular health, increase your risk of mortality. And then we have risk of infections and stuff. And then it's not just that what having chronic kidney disease and advanced kidney disease and severe lupus just affects your health. It affects your ability to work, your interaction with your family. So it has a lot of effects. So if we don't treat this soon, it can cause very long-term bad side effects. And the other thing that it has for these young females is that having lupus in the kidney increases significantly the risk of maternal fetal complications. And that's very important for patients at the age that are usually diagnosed. So that's why it's so important to monitor for this and treat soon. Okay, so next slide. So how do we minimize the risk? That's the most important. I scare you first. I don't want you to be scared. I want it to be proactive. So the important thing here is that a screening for this is essential. Okay, the soonest we diagnose this, the easiest it is to treat, and the less side effects long-term it will have. But chronic lupus nephritis usually does not cause any symptoms. Okay, it's not gonna come and tell, oh, I have like the patient said, what I'm gonna feel, what I'm gonna feel. You're not gonna feel. If you feel something, usually it is too late. Okay, so the way for you to diagnose this soon is to go to your rheumatologist as frequent as they tell you and get your urine checked every time. And if you leave your rheumatologist's office without a urine analysis at least every 3 to 6 months, you got to tell them, where's my urine? Urine analysis is essential for the early diagnosis of lupus nephritis, and it can save your kidney and eventually your life. So you got to make sure you get that test done. So if we diagnose it, if there's something abnormal in your urine, your rheumatologist has to act on it, okay? And then, I mean, not every abnormal urine is lupus nephritis, so I don't want you to be scared about that. But it's like, if there's something abnormal, if there's some blood there, if there's some protein there, we probably have to recheck that, confirm that. And if it is truly there, you should get probably sent to a kidney doctor soon enough, because then is when the decision has to be made if a kidney biopsy has to be done, because that's the only way we have nowadays to diagnose lupus in the kidney, okay, by a kidney biopsy. Again, your rheumatologist usually doesn't make the decision. He just have to be aware that it's an abnormal urine analysis that is persistent and suggestive of potential kidney lupus in the kidney. You have to see a kidney doctor. And then when we got you in the office, and again, we're going to get maybe up to 60% of you at some point, you understand? But if we get you early, if we suspect lupus nephritis, then the next step is the biopsy. And if the biopsy proves that, we got to start treatment soon, okay? So, and it's something that the more we take to treat, the more damage it's going to cause by the time we start the treatment. And most of that damage could be irreversible, and it accumulates over life. And the more flares, the faster you're going to get to that end stage kidney phase, okay? When we start treatment, again, this is for all lupus, and lupus is a very complicated disease because it's chronic, right? At least for now. I mean, is CAR-T going to change that story? We'll see. But for now, it's a chronic disease that is very variable, as Dr. Littlejohn said. Some people flare once in their life, some people flare all the time, some people never feel good in their whole life. So it's very, and then of course, you got to take medications. That's the only thing we know how to treat right now. To control the disease. So you get tired, you get side effects. I'm done with it. I mean, it's painful. So then maybe you stop them. And then what happens is that, unfortunately, this is important in general in lupus, but definitely in kidney, if you don't take the treatment as it is instructed, even if you feel great, the disease is going to progress. And the disease may come, or if you were in remission, but you stop the maintenance phase too soon, it may flare. And that flare is going to kill more nephrons, more of the filters. And that's going to accelerate the decline in kidney function. So it's very, very important, although it's painful to hell, that you stick to the treatment and stick to the monitoring to get that disease under control. Because flare prevention is essential. And that flare prevention is, how do we prevent it? With maintenance therapy. And if you're off maintenance because you passed that 5-year, how do we know if you flare? is because you're following every 3 months, because once you have kidney disease, every 3 months you got to get blood work and urine tests, even if you're in remission, because you may flare. And that's the only way we can know that you flared and we can treat you soon. Okay, so so it's just painful, but we got to do it. And of course, it's not just for the kidney doctor to treat the lupus in the kidney, but all the complications that come from having kidney disease, like hypertension, swelling, and all the comorbidities that come from the medications that we give you, like diabetes, obesity. Again, unfortunately, the treatments help, but also cause disease. So we have to, we as kidney doctors, we usually work on that, because we know that diabetes and hypertension and obesity affect the kidney, and the kidney affect the heart, and the heart affect your life. So we got to control all that. Okay, next one. So for you to get an idea, because I'm going to talk about new medications, but how to approach lupus nephritis once we diagnose. And there's different classes of lupus nephritis, but there's mainly 3 that we really actively treat. A few of them are more in the microscope, but the ones that we call proliferative forms, that are classes 3 and 4, or one that is called class 5, that it makes you leak a lot of protein, that is when this kid that Emily showed that was all swollen, no? There's usually a class 5, at least there's a component of that. We got to treat them fast, and that fast treatment, a strong treatment, is called induction. It's like the first phase of the chemotherapy. We got to do it now, because the soonest we control the disease, the less harm it will cause to those kidneys. Okay, the less scar is going to live there. We don't know how to treat the scar, so we got to prevent the scar. Okay, and treating fast prevents the scar. And then once we achieve that induction, then we have to maintain. Maintenance is important. Maintenance is there to prevent the flare, because the flare will imply another induction. And we don't want to give you all that medication again. We just want to maintain with a lower dose of medication that have less toxicity. Okay, so that's the importance of the induction. So I'm going to talk about the induction. So what does it mean to induce someone? Is that we're going to control the disease. And what is our objective? So how does lupus nephritis present? Many times presents with an abnormal urine analysis. The kidney filters are being inflamed. There's all these auto antibodies that are like just getting stuck in those little filters and are calling the immune system to attack it, and then gets inflamed and harm, and eventually they can scar these filters, right? But when these filters are not working, they let stuff leak through them that shouldn't. So that's how we know that they are being harmed. We see protein in the urine that shouldn't be there. We see blood cells in the urine that shouldn't be there. These things are in your blood vessels. They should not be leaking through the filter. The holes of the filters are big. They're just going through your urine. The urine is showing us what's happening in the kidney. That's why it's so important to get that urine checked, okay? So we want to make those things disappear. We want to heal those, like fix those filters to reduce the inflammation. Sometimes we can fix it completely. Sometimes we leave some scar behind. But if we do fix the filter, then those things are not going to show up in the kidney anymore. So from having protein to reducing the protein, that's part of we know that the induction is working. The protein in the urine is coming down. There's a goal of less than 0.5 grams per gram, or 500 milligrams in 24 hours. That's our goal. I mean, if I tell you my goal is that there's no protein at all, but at least we want it under that. And ideally, we don't want any blood there. I don't want blood cells like leaking through the pipes. So no blood, no protein. And if there's been decrease in kidney function at the time of diagnosis, because sometimes the kidney function remains low normal at the beginning for a while. But if we do see that there's a decline, we want that back up, improved. So that's complete remission. Everything looks back to normal. Can we achieve that? Always not necessary. So there's something called partial remission. We almost, we got somewhere there. And some patients don't respond. That is what we call lack of response. And you'll see that, unfortunately, the amount of people that don't respond or just partially respond is too high, even now. So that's what we're doing this talk. So this is what I told you about, like, what's the objective of trying to get the protein at least under 0.8, but we aim to 0.5 in 24 hours. We usually get 12 months goal. So that's our goal at 12 months. But that is associated with a prolonged kidney life. And if your kidney lasts longer, you live longer, okay? Next. here it tells you, this is an old study, but it tells you a bit of a feeling why it's important to achieve that complete remission. See, patients that achieve complete remission, they are 95% are alive in 10 years. Patients that have a partial response, 76% are alive. And patients that have no response, 46% are alive. This is all data. It's almost 20 years data, but you're going to see that we haven't changed. I mean, there's maybe a bit of improvement in cardiovascular outcomes in lupus, but still there's a gap, right? So there's a clear difference. How's your kidney going to survive? If you achieve a complete response, 94% of your kidneys at 10 years are still working. But if you didn't have any response, only 2 out of 10 people will not be on dialysis or had a kidney transplant. And the same thing, the survival on without dialysis at 10 years is kind of similar, but you can see that if you don't achieve any response, you're most likely going to be on dialysis in 10 years. If you achieve a complete response, most people won't be on dialysis in 10 years. So it's really, really important to achieve that complete response. Okay, next. So I want to give you a bit of a flair what happened with the treatment of lupus nephritis over the past many years. But this compared guidelines back in 2012. What do we use? How do we treat? How do we induce? These are induction guidelines from the KDO, that is like this international organization that lots of kidney doctors get together and decide how we treat diseases. And this is how we decided to treat lupus. And back in the day, like in 2012, I mean, the classic induction medications were cyclophosphamide or mycophenolate, right? And then we used to give high doses of cyclophosphamide in different ways. And we used to give very high doses of steroids. 10 years later, there was some studies came out there and showed that maybe we didn't need to give so much cyclophosphamide and it was as good. So we cut down the doses. Cyclophosphamide is a very toxic, it's a cancer medication, you know, that kills a lot of immune cells. But we learned that we could use less doses and we learned that we could use less steroids. So we started to cut down from very high doses of steroids to lower doses of steroids. But that's all we had in 10 years. No new medications, just maybe a better understanding that we maybe didn't need so much to treat and still would achieve a good response. Next. But with that therapy, that was our standard of care up to like a few years ago, only less than 40% of patients would achieve complete remission. So maybe 30% will have that kidney or alive in 10 years. So it was not great. So you were lucky you were in that 30%, but most people were not. And the chances of having a flare, and again, having an R induction and losing more kidney and accelerating kidney function was up to 60%. And still with that treatment, up to 30% reached dialysis in 10 years, okay? And of course, mortality was not perfect. So then what happened? Next. We need help, right? Something had to happen. So probably thank you for you guys from the Lupus Society that pushed some of this research. But we need ideas. We need to get this stage to the next level. Can we do it better? So people got together and go ahead. And they did something. So there were some studies out. So I'm going to show you three of the. So since that point, since 2021, till today, in the last 5 years, there's been 3 new drugs approved for the treatment of lupus nephritis. The first 3 drugs ever approved by the FDA for the treatment of lupus nephritis happened in 5 years, when we had like decades of no change in treatment prior to that, okay? So I'm gonna talk to you about the first one. This is belimumab that you guys already heard about. This is a biologic medication. It was approved for lupus back in 2011, but it was approved for lupus nephritis in 2020, at the end of 2020. This is a landmark trial that proved that, you can go next, and I'm going to tell you that. But basically, this trial, what it did was it compared standard of care, that is standard of care was either mycophenolate plus steroids plus Plaquenil, usually for everyone, or cyclophosphamide in the low dose cyclophosphamide, that Lupus plus steroids plus Plaquenil. That was the standard of care group. There were like 2 standard of care groups, plus minus this infusion, was an infusion during the trial, the belimumab, this biologic. Some group, half of the patients took just the standard of care, half of the patients added on this infusion. Okay. And they have the primary endpoint of this study, so what they wanted to reach, when they would feel that they make a difference, was not as stringent as a complete renal response, meaning less than 0.5 of proteinuria, was less than 0.7. So there's a teeny bit of a difference with the other two studies, and then, preservation of kidney function. So whoever got more of those people with better proteinuria, with better kidney function in the two groups, is better to add belimumab or not. And then, so basically what it showed, there were like almost 500 patients that in the group that received belimumab, 43% of the patients reached that endpoint, okay? Versus only 32% in the group that didn't use the belimumab. Meaning, if we add this biologic to the induction therapy of lupus nephritis, we have higher chances of achieving a better response. Of note, the complete response in this trial was pretty low because its complete renal response is less than 0.5, was only 30% in the belimumab group and 20 only imagine, this is a randomized controlled trial. Everyone is doing exactly to the T what the researchers are telling them, and only 20% at 2 years follow-up actually achieve complete renal response with the standard of care. This is terrible. You are right, it's terrible. I mean, the other one's 32 is better, but still it's terrible, correct? It's not great. And this is doing everything perfect. So I just wanted to put out there how much work we have to do. But, there was also a benefit that this biologic had, was that it had less flare. So once they achieved induction, in the group that was kept in belimumab, because the treatment was they were followed for 2 years. They have less flares during those 2 years than if they were just on mycophenolate or cyclophosphamide, etc. Okay, so bit less flare. So next one. This is kind of like, don't worry about that. So then the other drug that got approved like very soon after, and again, was a similar study design, standard of care alone versus the standard of care plus something else as induction to get that protein down fast, raise the kidney function if we can, to get the blood out. What it used was mycophenolate as the standard of care alone. They didn't use cyclophosphamide, so we don't have data on that arm because mycophenolate is the preferred induction therapy in most places. And added this drug is called calcineurin inhibitor called voclosporin. That is a kind of like maybe some of you have ever been on tacrolimus or like something like that. There's another calcineurin inhibitor that are used in lupus. But they added this drug and then they said, are we going to do better, with adding versus not adding? So then show me the results. And actually, the voclosporin group did better. So you can see the complete renal response here. Again, this was 23%, very similar to the belimumab study. Standard of care, just 20 plus percent. Voclosporin brought it up to 41%. Okay, and what it did that was very remarkable for the study was that it got the urine protein in half of the time under 0.5. So if you have a lot of protein in the urine and you have this drug brings it down fast. Okay, so people that have nephrotic syndrome are very swollen. This is a good drug to bring things fast. The thing is that this drug cannot be ideally prescribed if your kidney function is under 45%, because the medication itself can decrease kidney function in a more acute way. So they excluded these patients. So if there's severe kidney dysfunction at the time of diagnosis, we may not be able to add this drug at the beginning, okay? But this is the other drug that got added to the piping. So next. So then so in December of 2020, belimumab was approved by the FDA for the treatment of lupus nephritis. And in January of 2021, voclosporin was added, okay, to our pipeline. These are medications. This is what we were talking. Someone asked our triple therapy. In kidney disease, triple therapy has been proven to be better than just dual therapy with like cyclophosphamide. So we're attacking different pathways that gets better results. And the truth is, I didn't show this because I don't have too much time, but the side effect profile of in the two sides was not different. So there were no significant more infections in one side than the other. I mean, voclosporin can cause hypertension, like occasionally it rises potassium, but there was nothing significant between the two groups in terms of more infections and stuff. Belimumab, the same. Again, can cause like injection side reactions and all that stuff, but nothing was very critical. So similar side effect profile, better efficacy of the addition of the third drug. Okay, next. So after this came out, we know the experts got back together and then they reviewed the guidelines, right? So next. So now the 2024 KDO guidelines. So before we had 10 years between the two guidelines. Now we had only 3 because things move fast, right? So then finally, I put next. I'm gonna just kind of make it big, but no, go back. Yeah. So, but this is what they recommend now. This is 2024. I mean, things are changing. They have no, like, it's probably gonna change by next year. We recommend patients that have classes 3 or 4, with or without class 5, that's the membranous component, to be treated with glucocorticoids and either mycophenolate alone, that was, or low-dose cyclophosphamide, this is like old data, no? Or the combination of belimumab and either belimumab and low-dose cyclophosphamide or mycophenolate, or mycophenolate with a calcineurin inhibitor such as voclosporin, as long as the function is more than 45%. So they acknowledge, but it's still we're gonna still go on the 2 drugs only, right? But go next. But then the American College of Rheumatology, that were the kidney guidelines, but kind of like we're running a bit behind, said, why would we go 2 drugs if we had clear data that 3 is better, right? Unless it's a real contraindication, why we're gonna just do 2 medications? So again, sometimes people are very frail, they have side effects to one of the drugs. You have alternatives. And again, 20% of the patients will respond just to a mycophenolate and the steroids, or the cyclophosphamide and the steroids. But if you want to increase the odds from the beginning, and the faster you treat, the better that kidney will do over time, they said, no, triple therapy from the beginning, go back. So first line for the American College of Rheumatology 2024, triple therapy for any sort of proliferative lupus nephritis. And for the membranous part, that if it is alone, they were a bit more softy there because it's not such an aggressive disease. But again, we're starting to understand that the more we do, maybe, was better. Okay, next one. So now I'm going to switch at the end of the year to the last drug that has been approved. And this is like Dr. Littleton show you that picture with all these crazy people. Press the bottom again. Yeah. But this is like not as crazy, but it shows you there's a lot of things going on in your body when you have lupus, and there's different immune cells that are being activated, and we can target different pathways. And what the studies before show you that if you target more pathways at the same time, we achieve better response, right? So one of the central cells in the what we call in the cause of lupus is this B cell, the lymphocyte. I don't know if you heard what it is, but it's the one that throws the antibody, the antibodies that normally attack stuff that we want to attack, but in lupus attacks ourselves, right? So we don't want them there. So, and they kind of like, there's this like auto-reactive B cells, meaning B cells that attack our own body, that are in the center of the disease mechanism of pathogenesis of the disease. Okay, so it makes sense to target them. The drugs we spoke before are not necessarily targeted to the B cell. They kill B cells. Some things die, because the cyclophosphamide is a very systemic drug. Voclosporin is more like a T cell type of, so it goes on the other type of lymphocytes. But, there's ways that we can target that cell specifically, okay? So next. So have you heard about rituximab? I think Dr. Littleton asked that, but in my experience, many lupus patients have heard about rituximab because rheumatologists use it a lot. At least in my experience. I don't know, any one of you have ever been on rituximab? Okay. So rituximab it's a monoclonal antibody, again, that attacks the B cell, like a receptor in the B cell, and leads to, it depletes it, it kills it. Okay, so it makes your B cell number come down. Not just the lupus ones, but so it causes infections too. And there was some, rheumatologists have used rituximab for other diseases, mainly rheumatoid arthritis, and they're familiar with it. And sometimes they didn't have what to do with lupus, and okay, let's just do rituximab. And then some of these patients have kidney disease, and there was anecdotal data that they were doing better. Okay, so then one day some group of researchers said, let's study this. Let's add rituximab. This is all like 2013 or 12. So next. So they did this trial, was called the Lunar trial, was like, was published in 2012, many years ago. You can press the next button. I think it's just go ahead, because press it. But basically they added, this is back in the day, I mean, when they were thinking about triple therapy. Now it didn't pan out at that time. They added rituximab to mycophenolate and tried to do this triple therapy back then, but at that time, it didn't show any benefit. Why? I mean, now we're seeing benefit with triple therapy. Why back then it didn't show any benefit, right? So next. Press. So, I mean, the overall results were not different. So there was not a significant difference between the two, but there were some signals that maybe the rituximab group did a bit better in some things. There was more partial response. So patients that got a bit better, but not completely better than the placebo group. And these like things that we measure in your blood, your complements, your DSA, DNA, the numbers look better. Okay. And they needed less extra therapy for rescue, So there was a signal that was better, but they couldn't prove that it was actually superior. So it was not accepted as a standard of care, correct? Go back. No, next. No, it's fine. So just kind of like but despite this trial, there was a lot of people that were still using rituximab in patients that would not respond to anything with lupus in the kidney. So refractory lupus nephritis, when the lupus nephritis doesn't respond to the standard of care. Mycophenolate was tried, like cyclophosphamide was tried. This is all a standard of care. And then they will add rituximab, and many people will see an improvement. Many rheumatologists say, well, they're doing better. So they put all this data together, same as Dr. Wasi said, like in a meta-analysis, but here it's only 300, not like thousands like in the cardiovascular ones, but 300 patients. And next. And they show that actually adding rituximab in patients with refractory lupus nephritis usually help. People that didn't have a response, 40% that had a full response, 34% had a partial response, and some didn't respond. So there was still a signal there, but they couldn't show that in the study before, right? So go next. So why? So why was it? There's some technical things in trials that may blur the signal, the improvement. But the question was, is there something in the drug itself that, some people respond better than others? Why some people might have responded to the addition and some not? And again, every person is different, right? But one of the things that they were thinking is that, rituximab kind of kills these B cells, but it's not necessarily the same in every person. So that didn't have anything to do how many B cells were killed with the response of that patient, was one of the questions. Next. So they did this subgroup analysis. So they went back and said, okay, let's see of the patients in the Lunar trial back in the day that got rituximab, but actually depleted the cells completely. So they have no CD19 cells that are the cells that we look at as a marker of response to rituximab. They had none left. So then if they look at the complete response at 48 weeks, 47% actually achieve it. The ones that didn't achieve it were the ones that did not kill, that the rituximab did not lead to kill the cells for some reason, okay? So it was not actually it's just actually maybe they need a higher dose or a more frequent dose or whatever it was but maybe if you do achieve that depletion of the B cell, you do get a better outcome when you add it to the standard of care, okay? So next. So that's when this new drug comes to the story that Dr. Littlejohn mentioned in systemic lupus, but it has been approved actually first for kidney disease. That is called obinutuzumab. That is similar to the rituximab, but the rituximab is a mix between a mouse piece and a human piece. This is all human, so has less chances of causing a reaction of your body against the molecule, okay? Because sometimes people form antibodies against rituximab, and the rituximab works less because of that. But this has much less chances, and also is stronger. It really, really kills the B cells very fast, and more so than the rituximab. And they were using this again. Always many things of these things come from cancer, leukemia stuff. They were using it already, and they decided to try it in lupus patients. Okay, next. This is like just what I already just told you. This is before actually the lupus trial. This is in systemic lupus, in refractory systemic lupus. They had tried the obinutuzumab in patients that have resistant to rituximab. And some of them had these antibodies that I mentioned to you. And when they tried the obinutuzumab in patients with resistant to rituximab, next, they actually showed improvement, okay? So there were less systemic manifestations, lower levels of C3 and dsA-DNA. And one thing I didn't measure, but again, more depletion. Yes, there was dead. I mean, these drugs, we'll talk about that, are associated with increased risk of infection. They're potent drugs, okay? And many of the studies were done during the pandemic without knowing that the pandemic was coming. So people die of COVID, and this one patient died of COVID in this series, okay? But, they knew that, it was stronger and they could bypass this resistance to rituximab. So next, then is when it came to it was at the same time this study happening in the kidney realm was published in the same year. And they kind of like, what they did is what they did with belimumab and they did with voclosporin. They got a standard of care and they said, okay, standard of care plus obinutuzumab. And what happened? So this is a complete renal response. In blue is the people that got the rituximab. At the end of the 2 years, more than 40% had a complete renal response compared to about 20% in the standard of care. That is what we're seeing. So in this phase 2 was more for safety and, get the dose, right? There was a signal. So they decided to go ahead and did the phase 3 that included more people. Go next. And this is that was published last year, about a year ago, that was the phase 3 trial, that was there to see if it was safe and efficacious to add on this drug for the treatment of lupus nephritis on top of a standard of care. Go next. And included patients, with lupus nephritis, classes 3 or 4, that could have this component of class 5. They have to have urine protein more than 1 gram. They have to have like a function of the kidney at least of 30%. And then they did that, mycophenolate plus glucocorticoids alone, or mycophenolate plus obinutuzumab plus glucocorticoids, and then they achieved the complete renal response at 1.5 years. Okay? And then next. There were 270 patients, mostly women, mostly around 30 years old. Go next. And that's what they found. Obinutuzumab was able to achieve, the patients that took it were able to achieve a complete renal response at 76 weeks or 1.5 years, 46% of the patients versus 33% in the placebo group. So it was better, okay? So next. It did have more side effects, okay? And this is mainly infection. Again, this study was done in the midst of the pandemic. And there was no, go next. Oh no, well, it's not here because I had added exactly the side effects because the slide is like, anyway, but I'll tell you in the loud voice. But there were mainly infectious complications, and there were 3 deaths in the obinutuzumab arm versus 1 death in the placebo arm. And those 3 deaths, 2 of them were for COVID-19 pneumonia at the beginning of the pandemic. There was no vaccination. We didn't know anything about the disease. So that's not what we're seeing so much now, but it is to know that these drugs are very strong and there's an increased risk of having more serious COVID-19 infections, mainly, or any infection, if you are on this medication. So we have to be knowledgeable about that. It's not the same now having COVID that it was before. And when the pandemic was here, we barely ever prescribed rituximab to anyone because we didn't have this drug. But as me, I would not try not to. I kind of kept my patients on other drugs until I could, because what happens once you give it is 6 months in your system and you have to wait until your immune system builds up. But now, after the pandemic happened, I have lots of patients on rituximab and now also some patients on obinutuzumab, and so far so good. We have antiviral, so we can act on it, but it's something to keep in mind. Okay, so just for you to know, we have 3 new drugs approved for the treatment of lupus nephritis. They are add-on therapy, okay? So we are just not this drug. It's on top, because what we have, we were very, very, very doing very poorly. Now we're doing a bit better. but that's not perfect either. Okay, so there's a lot of things going. This is like a post. This is just was presented in an abstract just recently last month. So, but they kind of like review the data from the trial I just presented, and they realized that there was much less chances of a flare in the obinutuzumab group than in the placebo group. So 11% of patients on the obinutuzumab group had a flare within those 76 weeks versus 23% on the other side. Was much less likely to have a bad outcome in the obinutuzumab group. So that the bad outcome was death plus doubling of the creatinine, so halving of the kidney function, or treatment failure was much less common, 8% versus 21% on the placebo group. And also they showed an improvement in kidney function in the obinutuzumab group versus a decline in the other group. So it's showing, there's still, so it seems to help. Okay, so it's another tool we have. Next. Again, this is our other common side effects, infusion related, as you are, these medications have to be infused over many hours. So it's usually one dose in day one, another dose 2 weeks later. That covers you for 6 months. And then we repeat that pattern 6 months later, one dose, 2 weeks after, one dose. And then we can decide what we do after. But because there's like potentially you can redose at 1 year. We don't know if one time or 2 times. I mean, we don't know yet that. But that infusion has to be given very slowly, over 4 hours, sometimes even longer, because there can be a reaction. What they noticed that were clearly more reactions in the patients that got the obinutuzumab than in the patients that got just saline, also because it was placebo. But they were usually, most of them, mild, that they could be taken care of by slowing down the infusion or kind of stopping and maybe infusing later. Sometimes you have to give the drug over a longer time to make it better. We pre-medicate you with steroids, Tylenol, whatever. But there are options, no? Okay, next. So then now the last update, just go again. And this is kind of the last, this is the European guidelines for the management of systemic lupus with lupus nephritis. And as before, they had included our guidelines here, the addition of voclosporin and belimumab. Now we have, for patients with active lupus nephritis, especially with those with poor prognostic factors, we recommend combination therapy. Okay, so it's combination therapy of either mycophenolate or low-dose intravenous cyclophosphamide plus belimumab, or mycophenolate with a calcineurin inhibitor, just either voclosporin or tacrolimus, or mycophenolate with obinutuzumab. So now that are the recommendations today, the last recommendations that we have, okay? One thing that I didn't mention, but is very, very important, is the addition of this third drug allows us to very, very rapidly taper steroids. By 3 months, patients with lupus nephritis should be on 5 milligrams of prednisone, ideally. And that's what we taper, really, really fast. So that's a very, very major improvement that we had with that. Okay, next. So we have more tools, and hopefully we'll have more to come. There's studies coming. Next. There's some, of course, you heard about the CAR-Ts, and then again, there's a mistake there. I didn't put the age for some crazy reason in the 2 parts, but it's just his face. My last one had it correct. But, we are doing CAR-T for patients with refractory lupus nephritis, and I have 3 of my patients are, of those 9 that Emily has, 3 are mine. And now there are studies ongoing about like adding other triple therapy, like complement inhibitors, and other new medications. Like this is similar to belimumab, but stronger, lanalumab. There are trials that are opened. If someone is interested in joining, most of these trials are standard of care plus placebo, but the old standard of care. So it's a bit tricky, because it's kind of a bit tricky to go on the old times when we know that the new times are better, but there's some studies open if you guys are interested. So just to take away, lupus nephritis is common. It's the most common serious complication in patients with lupus. And despite the old standard of care, the risk of end-stage kidney disease and mortality remain very high. Delayed treatment is associated with poor outcomes. Proteinuria is what we consider the best marker of renal prognosis, and a rapid reduction is important. And I'll mention something about that next. And we have the new treatments, okay, that have improved the frequency of remission without significant increase in toxicity. And now we have this, like, that's all. And there's we have voclosporin, belimumab, and now obinutuzumab have been approved by the FDA for the use in lupus nephritis. Okay. So that's it. So I don't know. I mean, my intention was that you guys know how frequent it is, how important it is, what we have out there. There's a lot of things that I didn't mention about this in terms of how would you choose one or the other. There's reasons, and I can mention teeny bit about that. Lupus nephritis is one organ in a patient with systemic lupus that is affected many times in many different ways. So how that third agent, because mycophenolate or cyclophosphamide is still the bone, and we're going to use them. Mostly we use mycophenolate because cyclophosphamide can affect fertility, and we just don't like that too much in young people, and have a long-term risk of bladder cancer. So we try to minimize the use, although the doses that we use of cyclophosphamide nowadays are very unlikely to cause a problem. But we kind of lean many times to the backbone being mycophenolate. And then the third drug that we add depends on the systemic disease. Again, if there's belimumab is pretty good for joints and skin, but definitely joints, musculoskeletal. So if someone has a lot of those symptoms, we may add belimumab. It's not as good in patients that have a lot of urine protein in terms of reducing the urine protein fast, so may not be the ideal drug for someone who is leaking protein like a lot. So then maybe voclosporin will be better as long as the kidney function is not bad. But the obinutuzumab is very, very good on people with a lot of protein too, and we can use it with kidney function down to 30%. Again, depends on the risk of infection, the frailty of the person. What else? I mean, there's so many different reasons. Obinutuzumab that just came in New England Journal of Medicine showing the results of the use of obinutuzumab in systemic lupus. And it showed improvement in a bunch of systemic manifestations. So again, I always work with the rheumatology, unless it's kidney limited disease, to decide the third drug, because we have to attack the whole disease, right? It's the best for the systemic disease, not just the kidney. But anyway, that's it. Thank you.
Okay. Thank you, Dr. Provenzano. It's wonderful. Okay. Any questions from our audience members? Okay. Let me come your way.
Hi, my question was, in the beginning, you're talking about having blood and protein in your urine as a lupus person.
Mhm.
Okay.
You shouldn't, but you could.
Okay. Now, how does the lupus person know to go to the doctor to get that checked, and the doctor not just checking for whatever's in your blood system as far as the pills you're taking?
Rheumatologists, yeah, the American Society of Rheumatology guidelines tell the rheumatologists that they have to be checking urine analysis at least every 6 months, minimum, because they got to catch the lupus in the kidney. Okay, so if you see in a rheumatologist, the rheumatologist has to be checking your urine. Most rheumatologists will check the urine every visit they see someone with lupus. You should see the rheumatologist though. So as a lupus patient, you have to be aware that you can't just spend a year without seeing a physician. You have to go get checked.
So
Even if you have no symptoms, you
So-
have to get checked.
what's the symptoms for the lupus patient?
Well, again, the kidney disease causes no symptoms sometimes. You can present
Okay.
bloated like a balloon, but that's way too far. You can present with kidney failure requiring dialysis. But if you are presenting like that, you're way down the way for me, the way for us to prevent that you have kidney function loss at reach dialysis or transplantation is that we capture that disease when it's giving you no symptoms. And this is like a screening colonoscopy or a screening mammogram, right? There's no symptoms. We do it because we know we can capture the disease before it gives you any symptoms. And if we act, then your prognosis improves. Same thing here. If that's why it's a screening test, we got to do it because if we find the disease soon enough, we prevent complications. So most of the time, you're not going to have a symptom.
Thank you.
You're welcome.
If you're always showing protein in the urine, is there something else that could be happening if your rheumatologist isn't doing anything about it?
Well, this is a great question, and it becomes much more complex. The causes of urine protein are many, not just lupus. In young populations, in a young person, usually with lupus, young person, that someone is not morbidly obese, does not have hypertension at base, and doesn't have diabetes, if there's suddenly appearance of protein, the most likely thing is going to be lupus. But if lupus affects someone who is older and has diabetes for many years, like hypertension, that urine protein could be secondary to a different disease. Okay, that's why that biopsies, and sometimes we do the biopsy and there's lupus activity and there's signs of diabetic kidney disease. And diabetic kidney disease can give chronic proteinuria that we don't treat with immunosuppression. Okay, so all that, but the kidney doctor should help decide. There are some people that have a scar in the kidney that immunosuppression that will cause urine protein that cannot be fixed with immunosuppression. There is when we have to use what we call RAS inhibitors like losartan, lisinopril. Now we're using these SGLT2 inhibitors like Jardiance or Farxiga. That's when we want blood pressure control with blood pressure under 130/80, weight control, because all that will increase proteinuria. Treatment of diabetes, prevention of diabetes, all that. There's many different things. So it's not just the lupus. If you add on to the lupus nephritis, hypertension, obesity, that kidney will fail much faster. So that's why it's our goal as nephrologists to make sure that every risk factor for progression is controlled, because otherwise you're going to lose your kidney fast. Thank you. No.
Could you, I mean, you mentioned the SGL2 inhibitors. Can you just comment on that and their use in patients with lupus nephritis?
I know there's some data out there, but I can personally tell you that I use them. If I have to, I use them quite a bit. If I know not to treat immunologically mediated proteinuria, but these SGL2 inhibitor are these drugs that you might have seen online, Jardiance, Farxiga, that are used to treat diabetes, but they have been shown to reduce cardiovascular outcomes, including like coronary artery disease and heart failure and yada yada, and actually improve mortality in patients with cardiac disease. But also like have a role in preservation of kidney function in patients with chronic kidney disease, mainly when there's protein in the urine, for whatever causes that, if it is diabetes or it is lupus, a scar, obesity, whatever it is. So if there's that kidney when we do the biopsy has some sort of lesion that is not due to lupus or has scar from prior lupus injury, that will tell me that proteinuria is probably never going to go away completely with immunosuppression, then we have a role to start these medications because they have been shown to prolong kidney function over time and have like a benefit in mortality too and cardiovascular health. So yeah, we use them. Same thing with the drugs to lose weight, like the GLP-1 agonists.
Any other in-person questions? Okay, Alex, do we have any?
All right. Have you seen any reversals in lupus nephritis and SLE patients with using medications such as Farxiga without having any A1C involvement?
Yeah, we use this. It's not reversal, but they help if there's persistent proteinuria or there's like chronic, even if there's no proteinuria, but usually lupus patient with some injury will have some proteinuria. If there's chronic kidney disease that I can say establishing the kidney with scar, SGL2 inhibitors have been shown to slow down the decline of kidney function over time, independent of the diabetes diagnosis.
Okay, is that it for home? Okay.
All right. When are SGLT2 inhibitors, ACE inhibitors, or ARBs used to prevent chronic kidney disease in SLE patients?
I don't know if we use them to prevent it. We use it when there is already. We don't use it yet, like to prevent. I mean, but if you don't have, if there's lupus nephritis already established, if the patient has hypertension, we will probably aim to starting a lisinopril or losartan type of medication as the first line, as long as there's no contraindication. But they are not used for prevention. Okay, they are used when there's established disease.
Okay. We know the answer to this one, but I'll let you do this PSA one more time. Should I be concerned that my rheumatologist never takes a urine sample? 13 years and not one urine test. Usually my family doctor does, but at my last annual appointment, no urine test.
I would say yes.
All right. And one more online. My daughter's rheumatologist had tried her on rituximab, then switched to Orencia last year as my daughter was having swollen joints in her fingers. Should I ask her rheumatologist about obinutuzumab.
Obinutuzumab. But
Yeah.
Orencia is more for arthritis, right? I don't think they use that too much for lupus. Does she have rheumatoid arthritis too?
So she no, maybe not. She is 16 and diagnosed 4 years ago, class 2 lupus nephritis.
Oh, just class 2. I don't know about the Orencia. That kills me. I need Emily for that. I don't usually see that. I think it's a discussion. I mean, what is exactly, I can't comment as a rheumatologist about joint disease management. For lupus nephritis class 2, there's no indication to augment immunosuppression beyond what is indicated for the management of the systemic lupus. We just want someone on plaquenil if they have a lupus nephritis class 2, but we're not going to start mycophenolate or anything strong. Because class 2 is a very, very incipient form. It does need very close monitoring because any class of lupus you can have class 2 today and class 4 tomorrow. So it's like, you're not fixed with that. So it has to be monitored every 3 months. Yeah, but I would not be able to answer. I think the obinutuzumab has not yet been approved for systemic lupus, but it's probably going to happen after this study has been published.
Great. I'm going to ask one of the pre-submitted questions for you, and then we will wrap up. Can biologic treatments, I think I know the answer to this, I think you touched on it, but can biologic treatments reverse the damage that has already been done to my kidneys?
So as per now, we don't think so. So we don't think we can reverse. I mean, let's put it this way. Reverse what type of damage? There's acute damage, inflammatory damage, that can get reversed. Chronic damage, scar, when in the biopsy they read glomerulosclerosis or interstitial fibrosis or tubular atrophy, those words that talk to a tissue that died, we don't know how to reverse that. Some tubulars can, so maybe we will. So I'm not saying, but these drugs are there to reduce the inflammation that if it is persistent will lead to the scar. So the inflammation, yes, will look much better. You sometimes do a biopsy of a lupus patient, it's all inflamed, treat aggressively, rebiopsy after and looks good. So the inflammation, whether it was pure active inflammation, that can be reversed completely if we treat soon. If we don't treat soon enough, then the scar happens. That's what we don't know how to fix yet, if we can. It's like a scar in your skin,
Just stays there.
Yeah.
Thank you, Dr. Provenzano.
No,
Very
you're
wonderful
welcome.
information. Let's give her a round of applause.
Thank you.
Okay, I am going to conclude the program right now. I want to say thank you to our virtual audience for joining us and remind them that an evaluation will be coming with a lot of information as well provided by our pharmaceutical companies who joined us today. So thank you so much. To our in-person audience, thank you so much. I'll ask you to stay with us for just an additional minute or so. There in the folder that you got, there are 2 evaluations.